Hello. We're going to be going over perinatal mental health as our webinar. My name is Marta.
And my name is Marie.
I'm Serena.
I'm Maddie.
And I'm Grace.
Our learning objectives overall for this webinar is to be able to define and describe mental health in pregnancy, baby blues, postpartum depression, and postpartum psychosis.
So the importance of mental health was mostly emphasized on the postpartum stage, but there is now a greater focus on the entire process, from conception through the prenatal period to birth to postpartum. And about 10% of pregnant women worldwide experience a mental disorder, with higher rates in developing countries. Prenatal depression is a mood disorder characterized by sadness, low self-esteem, sleep disturbances, and anxiety. And depression during pregnancy has also been linked to adverse outcomes like low birth weight babies and preterm labor. And in these offspring, there's a higher risk of developmental disorders, adolescent neurodevelopmental issues, and social and mental problems in young adulthood. This just highlights how crucial the pregnancy period is for both mother and the baby. And the exact mechanism of perinatal depression is not exactly known, but it can be due to a combination of reasons like hormonal changes, genetic predisposition, and environmental stressors. Hormonal changes, particularly estrogen, progesterone, and cortisol, can impact neurotransmitter function, leading to mood disturbances. Factors like sleep disturbances, inflammation, and changes in brain structure and function during pregnancy may also increase risk of depression. And a history of depression or anxiety or current diagnosis of mental health disorder, especially if not well controlled, are significant risk factors for antenatal depression and anxiety. Poverty, migration, extreme stress, exposure to violence, history of abuse, emergency and conflict situations, natural disasters, and low social support are also risk factors for perinatal mental health disorders. And pregnant people who experience chronic stress are also at high risk of postpartum depression and anxiety. Early and effective recognition can be done in each prenatal visit with screening tools like the Edinburgh Postnatal Depression Scale, or EPDS for short, which was originally made for postpartum patients, but research has shown it to be useful for catching prenatal depression early on. Early screening and management is crucial to the health outcomes of both parent and infant, as unhealthy coping behaviors may rise, such as smoking and substance use, which carries even more adverse risks. Diagnosis is usually made when at least 5 depressive symptoms are present for at least 2 weeks. And treatment options include things like psychotherapy, such as cognitive behavioral therapy, support groups, and medication. And another tool for antenatal mental health is to establish social support for the pregnant person to lower risk of depression, stress, anxiety, and associated complications. A lack of social support has been found to be linked to feelings of despair, anxiety, and self-harm. And educating and involving the childbearing person and their partner on how to support each other during the pregnancy and postpartum period, including education on mental health, is an intervention to raise awareness and strengthen their bond. A healthy marital relationship also plays a role in perinatal mental health.
Okay, so it's important to have an understanding of the baby blues when discussing postpartum depression, as these two topics go hand in hand and can seem similar based on the symptoms. So differentiating the two is important. The definition of the baby blues is a temporary period of about 5 to 10 days after birth in which the mother may experience labile emotions. These can be symptoms such as crying spells, fatigue, insomnia, anxiety, sadness, and anger. And to answer the question below, what's the difference between baby blues and postpartum depression? It's important to note that the baby blues has a short duration and these feelings should dissipate around the 10th day or within 2 weeks, whereas postpartum depression does not. So there are a few risk factors that could potentially lead to the development of baby blues. Recognizing these factors are important so that the mother can get support before she experiences it. These include risk factors of medical or family history of depression, cultural impacts, premenstrual dysphoric disorders, financial stress, and relationship conflict. The pathophysiology of the baby blues is unknown, as there's no exact cause or reason that some women develop it. However, it could possibly be a result of the dramatic change in hormones once the woman has given birth, which means that some women who are more sensitive to an alteration in hormone levels are more likely to experience the baby blues. So when assessing for postpartum blues, various questionnaires and scales are used in order to make a diagnosis. The Stein Maternity Blues Scale was created in 1980. This scale scores symptoms from 0 to 26. These symptoms include depression, crying, anxiety, calmness, restlessness, exhaustion, dreaming, appetite, headache, irritability, poor concentration, forgetfulness, and confusion. And at the end of the assessment, a scoring of 3 to 8 on the scale indicates mild postpartum blues, and a scale of 9 or greater indicates severe postpartum blues. The Edinburgh postnatal depression scale is also beneficial scale to use, as it measures depression in the postpartum stage. So if there's a positive result with this screening, further assessment will be required. Social supports and treatment. Supportive management is the most useful technique when coping with the baby blues. So ensuring that the mother has adequate support from friends, family, and their partner is crucial. As with this support system, they can establish a daily routine, and the mother can receive help with difficult tasks, especially while she's experiencing the blues. Treatment options, it's kind of similar to coping with it in social supports. This can be, various treatments can include practicing self-care, encouraging the mother to rest when the baby does, if possible. Even things like just changing their environment can help be beneficial in treating the baby blues.
So before we start our postpartum depression piece, I just want everyone to, in their own words, try to define postpartum depression. You feel free to pause this video if you need some more time, and then we can go right into our learning objections and the definition of postpartum. So our learning goals is to define and describe postpartum depression, identify key risks, understand and apply key assessment tools, explain the pathophysiology of postpartum depression, and explore treatment options. Postpartum depression is a mood disorder that affects individuals after childbirth. It is characterized by severe, persistent feelings of sadness, no interest in the baby or in activities, increased fatigue with sleep disturbances, and thoughts of harming oneself or the baby, and feelings of guilt and worthlessness. It interferes with not only infant care, but of daily life. It usually occurs within the first month of childbirth and can span to weeks or months afterwards. 23% of Canadians who have recently given birth have reported postpartum depression or some sort of anxiety disorder. Some studies have also shown that male partners are also at risk or at greater risk for paternal postpartum depression if the mother is diagnosed, and this shows the shared impact of postpartum depression and highlights the need for family-centered care.
So the risk factors for postpartum depression are multifaceted. Physical, environmental, biological, and emotional factors all play a role in increasing the likelihood of developing this condition. The history of depression or anxiety is one of the strongest predictors of postpartum depression, and women who have experienced these conditions are much more likely to develop postpartum depression after childbirth. So for physical risk factors, I'm going to go over a couple things of each of the different categories. So for physical, this could include a cesarean section delivery, as this often is a more complicated recovery process, and the potential for physical pain or complications during healing is increased, which puts the woman at an increased risk of postpartum depression, as well as gestational diabetes, as it can also complicate the postpartum period and affect the mother's physical health and overall recovery, as well as postpartum anemia or low iron levels can lead to increased fatigue and mood changes, both of which would contribute to the onset of postpartum depression. For environmental factors, a lack of support would be something that falls into this category, as a strong support system is so crucial in the postpartum period. Socioeconomic status is well documented as a risk factor, as well as this would include like financial stress, housing instability, or limited access to healthcare, as well as exposure to violence and abuse. Women who have been exposed to violence or abuse either during pregnancy or in the past are at an increased risk for postpartum depression, as this trauma can have a lasting emotional effect and complicate the postpartum experience. Biological factors, there's such drastic hormonal changes after childbirth, and the body undergoes significant hormonal shifts. These fluctuations can contribute to mood swings and depression, making women more vulnerable, as well as genetics. If there's a family history, it plays an important role in the postpartum depression risk. Women who have a family history of depression or other mental health disorders are more likely to experience postpartum depression themselves. Finally, let's explore some emotional risk factors. Just a stressful life event. The postpartum period is such a high stress level event, and the added pressure during the postpartum period can be overwhelming for new mothers, as well as the challenges of caring for the newborn, including disrupted sleep patterns, feeding difficulties, and the demands of the constant care can be emotionally taxing and increase the risk for postpartum depression. As well, lastly, negative pregnancy or delivery experiences are more likely to develop postpartum depression as well.
So for the pathophysiology of postpartum depression, it's quite complex. There's a couple of different factors to it. The first one is a component of hormonal dysregulation. There's often a rapid drop in estrogen and progesterone during childbirth that can contribute to mood disturbances. Estrogen impacts serotonin levels, and if it results in lower than normal serotonin levels, then it could impact depressive mood, and as well as if there is a decrease in progesterone, that can impact anxiety and mood stability. During pregnancy, the hypothalamic pituitary adrenal axis is hyperactive, which leads to an elevated cortisol levels in the body. During postpartum, there's a fluctuation of cortisol levels as a result of altered stress responses. Elevated cortisol levels can also suppress oxytocin, and when oxytocin release is impacted, it can make it difficult for the mother to bond with baby. And whenever there is a reduction in oxytocin, it can also worsen dopamine and serotonin levels, which can exacerbate depressive symptoms as well. During pregnancy, the mother's immune system is also suppressed in order to protect the baby, because the baby is viewed as a foreign object in the mother's body. This causes an increase in anti-inflammatory cytokines, and when childbirth occurs, there's an increase in pro-inflammatory cytokines as a result to the stress of labor. This inflammation ends up breaking down an amino acid that is a key ingredient to produce serotonin in the body, which again causes a decrease in serotonin. Moving on to assessments, one thing you should ask yourself before I begin is, what type of questions would you ask as a nurse with someone who you suspect might have postpartum? First thing is try to provide a non-judgmental environment, and try to be mindful of your nonverbal and verbal communication. Many of these women feel very guilty to be seeking help because they're viewed as bad mothers. So being able to establish therapeutic relationship and trust is very important. There are some screening tools that we can use. We've touched on the Edinburgh Postnatal Depression Scale a little bit already. There is also patient health questionnaire that assesses depression severity overall. There's also parenting stress index that can assess the severity in parental stress. A higher level usually indicates higher parenting stress. And additionally, there's also multidimensional scale of perceived social support that can assess the perception that the mother has of social support. A higher score in this case indicates higher perceived social support. Data collection is also crucial. Many facilities suggest a number of different timelines. The first one can be from 2 to 3 days after delivery, 6 weeks postpartum, 3 months postpartum, 6 months postpartum, and 1 year postpartum. Assessments can be done anytime that you suspect anybody might have postpartum depression, but these are just a general rule of thumb. Other assessment components that you might be able to ask are socio-demographic information, any history of previous mental health, any sort of distressing experience that occurred prior to pregnancy, as it can help establish if there's any contributing factors to postpartum depression. And finally, you can also look for certain symptoms. So any changes in sleep, appetite, or mood, any difficulty bonding with the baby, or any lack of interest in other activities, thoughts of self-harm or harming the baby, feelings of guilt or hopelessness, anxiety, or any loss of interest or low energy.
So, when it comes to treatment options, I want everyone to take a moment and think of some of the challenges that might occur when treating postpartum depression. Ultimately, the treatment depends on the severity of the symptoms, how much they affect the mother's daily life, and her ability to care for the newborn. So psychotherapy is often the first step, but studies have shown that it's only slightly effective for treating postpartum depression. If symptoms persist, antidepressants are usually recommended. Selective serotonin reuptake inhibitors are the first choice, and they, due to them being safe and having a low toxicity. If the SSRIs don't work, another option could be the serotonin norepinephrine reuptake inhibitors. Because of the hormonal changes during pregnancy and after birth, hormonal treatments are also are being explored as potential options as well. In the more severe cases, or when psychotic symptoms evolve, ECT might be considered. While primary care physicians can manage most cases, more severe ones may need emergency psychiatric care. And throughout all the treatment, it's crucial to keep both the mother and the baby's safety in mind. So the next topic that we're going to talk about is social support and why having strong social support is so important. Strong social support in women with postpartum depression helps reduce the feelings of isolation, provides emotional comfort, and encourages women to stay engaged in their treatment. It almost makes them feel like they're not so alone in this, and that they have a team behind them, cheering them on and rooting them on and supporting them and loving them, honestly. Research shows that women who face marital issues during pregnancy are more likely to develop postpartum depression and often feel lonely and undersupported. The risk of postpartum depression is closely linked to the level of support a woman receives from her spouse and her satisfaction with that support, and whether her expectations are being met. Support from family and friends plays such a significant role in improving coping strategies, boosting recovery, and ensuring the mother's well-being during this emotional and challenging time. We're now going to do a self-reflective question together. And this is about cultural factors that you should be aware of. So we live in such a multicultural society, and it's important to reflect on how cultural factors can shape and influence perceptions of postpartum depression. I encourage everyone to take a moment to consider how cultural norms around motherhood might impact how women view and navigate their emotional struggles. Think about the stigma that may prevent women from seeking help and the traditional practices like herbal remedies or rituals that may be favored over formal mental health support. By acknowledging these cultural influences, we can gain a deeper understanding of the unique challenges women face and provide more culturally sensitive, compassionate care for those experiencing postpartum depression.
The last topic that we're going to be talking about is postpartum psychosis. So it is a rare but severe psychiatric emergency affecting approximately 1 to 2 per 1,000 women, posing a significant risk to mother, infant, and their families. Postpartum psychosis is not as common as postpartum blues or depression. Childbirth is the key triggering factor, potentially leading to severe mood disorder, and if untreated, it can result in serious harm. It is most often seen with mothers who have a history of bipolar disorder, but may also occur with major depression, with psychosis, schizophrenia, or schizoaffective disorder. So some of the signs and symptoms. So this has a different presentation than psychosis. It can be rapid onset that normally starts sometimes between the 48 hours after childbirth, but symptoms usually begin after the few weeks. Typical onset is 3 to 10 days after childbirth. Delusions that are more often centered around the infant, they're usually fixed, false beliefs that are not culturally based. Paranoid thoughts that someone may be trying to harm her or her baby. Hallucinations that may be sensory, such as tactile, visual, auditory, and olfactory sensations. Dysphoric mania and depressive symptoms may cause suicidal ideations of self or thoughts of harming the infant or others. They may exhibit prodromal symptoms that could be mistaken for a medical illness, such as infection, thyroid disease, parathyroid disease, anorexia, substance-related symptoms, blood loss, tumor, autoimmune disorders. Disorganized thoughts and unusual behaviors are other symptoms that they may present with. So for risk factors, like I said, history of bipolar disorder, it places the mother at a 50 to 80% chance of developing postpartum psychosis. 40% of women have no history of psychiatric illness. Postpartum psychosis after a previous childbirth or a family member that has had postpartum psychosis. Stress, genetics, first pregnancy, any discontinuation of psychiatric medications during pregnancy, or sleep deprived. So for the patho, stress has been found to be linked with postpartum psychosis, as postpartum rapidly declines estrogen levels and increases sleep deprivation. In laboratory studies, those with postpartum psychosis were found to have elevated CRP, cortisol, and have some sort of history for childhood stress or maltreatment. For genetics, there's been genetic risk scores for major depression disorders and schizophrenia. They're linked and have an increased risk of postpartum psychiatric illness. Women with first onset postpartum psychosis have higher polygenic risk scores for bipolar disorder and schizophrenia, while their scores for major depression are similar to healthy controls. Low folate levels, which are common during pregnancy, have been connected to psychiatric disorders and genetic mutations affecting the folate metabolism. And high homocytosine levels is a result of low folate and may also play a role in postpartum psychiatric illness. So for neuroimaging, they found that pregnancy and postpartum involve dynamic brain changes, which may increase vulnerability to mental illness. Women at risk of postpartum psychosis exhibit increased connectivity in the dorsolateral prefrontal cortex, unlike those with non-postpartum psychosis who showed reduced connectivity. Difference in working memory and emotional recognition were observed in women at risk, and changes in executive functioning and emotional processing were also noted. So for endocrine factors, they found that steroid sulfatate and DHEA ratios may play a role due to their effects on estrogen levels, which decline sharply postpartum. STS deficiency may reduce neuroprotection, increasing susceptibility to postpartum depression. And thyroid function, they found that larger right thyroid lobes and higher FT4 levels suggest a possible link between thyroid function and postpartum depression. For immune system and inflammation, T cell activity may influence brain myelination and potentially contributing to psychosis, but they've not found any major risk factors when it comes to infections. So for assessments and treatment, a postpartum screening for current mental health problems, any history of psychiatric treatment, a family history of mental illness. Screening may include the EPDS screening that we have talked about and a postpartum depression scale. A score of 12 or higher may indicate further evaluation. A psych evaluation would include an onset, nature of symptoms, presence of any death wishes, suicide or any suicide plans, impact of symptoms on patient's behavior and functioning, patient and family history of psychotic episodes, and the safety of the child and others in the patient's care, and if there's any presence of substance use. For a medical evaluation, we want to rule out other diagnoses, so using serum and urine laboratory testing and neurological testing, such as testing for CSF fluid, MRI, and EEG. A physical exam that would include current medications and testing the illicit substances or alcohol. Diagnosis, the DSM-5 does not classify postpartum psychosis as a diagnostic entry. Instead, they're assigned a diagnosis based on primary mental disorder. So major depressive disorder, bipolar disorder, or brief psychotic disorder will all be examples of that. But they would put an addition of the specifier peripartum onset if the episode was during pregnancy or within 4 weeks of postpartum. For treatment, our number one priority is always ensuring safety of the mother and child. Typically, a hospitalization is required. Some hospitals allow supervised daytime visits with the infant. We were never to leave the mother alone with the child. Outpatient treatment is rare and requires reliable support and daily check-ins. For initiating medication, normally it's a combined treatment for most, so antipsychotic medication and lithium. There is a high likelihood of later bipolar disorder diagnosis, and there's a different approach for general psychosis treatment. For lithium, normally this will last up to a year that we'll have people on lithium treatment. And for antipsychotic treatment, the preferred is second generation antipsychotics over first generation due to lower risks of side effects. Normally this is a 3 to 6 month for continuing antipsychotics. You may have to use benzodiazepines such as lorazepam for severe agitation or insomnia. And alternate treatments will include, like, combined with medication, the use of psychotherapy and alternative health modalities may be used.
So we created an interactive case study to help apply your learning. This case study follows Sarah. She's a 30-year-old female, first-time mother that gave birth 6 weeks ago to a low birth weight baby girl. She lives with her husband, Eric, who is very supportive. Sarah came for her routine postpartum follow-up at the clinic and expressed persistent sadness, exhaustion, and difficulty bonding with her baby. She felt overwhelmed, experienced feelings of guilt and worthlessness, and struggled to sleep despite being very tired. So the symptoms she's experiencing is persistent low mood, irritability, frequent crying, exhaustion, trouble sleeping, loss of interest in eating or socializing, difficulty concentrating and making decisions, withdrawing from family and friends, and feeling guilty for not bonding with her baby. For the first question, it's asking, what are the primary signs and symptoms of postpartum depression that Sarah is experiencing? So we want to select all that apply. Option A is persistent low mood, irritability, and frequent crying. B, excessive energy and motivation to engage in social activities. C, difficulty concentrating and making decisions. D, increased appetite and desire to socialize. E, exhaustion, trouble sleeping, and loss of interest in eating or socializing. F, withdrawing from family and friends and feeling guilty for not bonding with baby. The answer will be over here. The correct answers were A, persistent low mood, irritability, and frequent crying. C, difficulty concentrating and making decisions. E, exhaustion, trouble sleeping, and loss of interest in eating or socializing. And finally, F, withdrawing from family and friends and feeling guilty for not bonding with the baby.
And for question 2, how can Sarah's feelings of guilt and worthlessness impact her ability to care for herself and her baby? A, she may feel motivated to perform her duties more efficiently despite the sadness. B, she may struggle to bond with her baby, which can affect her emotional connection and caregiving. C, she may experience difficulty performing physical activities, but continue to care for her baby without issues. And D, her feelings may drive her to overexert herself in an attempt to appear perfect. And the answer is B, she may struggle to bond with her baby, which can affect her emotional connection and caregiving.
So question 3 is, which mental health assessment tool is most appropriate to screen Sarah for postpartum depression? So A, we have the EPDS, B, the Generalized Anxiety Disorder 7, C, the Depression Anxiety Stress Scales, and D, the Hamilton Depression Rating Scale. So the answer for this would be A, EPDS, which is a standardized screening tool designed to assess the presence and severity of postpartum depression. So in this picture, you'll see that the tool consists of 10 questions, each addressing different symptoms of depression. It is used to help healthcare providers identify women who may need further assessment or intervention for postpartum depression. So for the scoring, for 0 to 6, it's none or minimal depression. 7 to 13 is mild depression. 14 to 19 is moderate depression, and 20 to 30 is severe depression.
Well, the healthcare provider completed the EPDS with Sarah, and she scored 10, suggesting possible mild depression. Based on these findings, there are some interventions we could recommend to help support Sarah's mental health. One being psychotherapy, so that can be counseling, cognitive behavioral therapy, which can help Sarah develop strategies for coping and address any emotional challenges she's facing. SSRIs may be needed, especially if her symptoms persist or get worse. Social support, we do want to encourage Sarah to lean on her partner, her family, and friends to provide emotional help, but also practical help around the home and caring for the baby. And sleep hygiene. So we want to educate Sarah on strategies to improve sleep, because poor sleep can contribute to mood disturbances. And also postpartum social support groups where she can connect with other new mothers through these support groups and she can feel less isolated and have a space to share her experiences. And then we can also send a referral to Healthy Baby, Healthy Children program. It's a public health service where a public health nurse can do home visits, give support in parenting and education, and also additional resource to help with Sarah becoming a new mother.
We have attached a TED Talk resource for your learning. It can be self-directed if you choose to. And this video just discusses the importance of openly addressing postpartum depression and aims to raise awareness and reduce the stigma around postpartum depression.
We also included a resource if you know anyone that might be experiencing postpartum depression. And that concludes our webinar. These are all our references. Thank you so much.